Evening. Weird saying evening. Hope everyone's okay. Looks like we've got a few people live, so that's good. If you want to drop us a message in the chat, if you've got any questions or just want to make a comment, then feel free to do that. Welcome back. It's been just over a week and a half, no, more than that, about 2.5 weeks because of the bank holiday and then not doing Monday. So yeah, we left off last time where we were looking at the small muscles around the hip. Um, good morning. Good morning. See, I'm so used to saying it. Good evening. I get to watch the Magic live. Excuse me. Um, it's nearly past my bedtime, Simon. Evening, Martin. Yeah, do you know what? I feel exactly the same, Martin. Way past mine as well. Yeah, I was going to wear one of those hats, that they used to in like Mary Poppins films, like one of those hats you wear to bed. So yeah, welcome everybody. Thanks for joining in. So yeah, we did the rotator cuff of the hip last time, and we looked at some labral pathologies because we'd done the connective tissue before that. So now we're going to move on to the. So we've done all the kind of deep musculature of the hip. So the six kind of rotator cuff muscles, although I kind of call them that. They're not called that, but it's like the rotator cuff in the shoulder. It's pretty similar setup in the hip, so that's why I call it that. And then we're going to have a look at the bigger superficial muscles of the hip. Okay, so that's where we're going to go now. And made a little mistake on the intro because I said anterior and medial muscles, but we're going to have a look at the posterior and medial muscles. So hopefully, yeah, that'll be okay for everyone. And obviously, we will do the anterior ones. We'll do them a little bit later. So let's get going. Excuse me. Right. Yeah. In fact, before we do that, yeah. So the reason I couldn't do Monday, some of you may have seen on our Facebook group, but we're taking over the motivational interviewing course that Gary Mendoza runs at the moment. So he's been training myself and Dan Williams over the last year to take on that course and start running it. And we're going to. It was mainly geared at the fitness industry, and that's mine and Dan's background. So we're going to continue to do that. But obviously, we now work in healthcare, so we're going to tweak it slightly for kind of sports therapy, physiotherapy, that kind of thing. So if anybody is interested in that, then have a look at the movement therapy Facebook page, and there's some details on there. So that's where I was. I wasn't skiving on Monday. I was actually doing some really cool stuff. Right then, so posterior thigh. Let's get going. So let's grab my arrow. There we go. So yeah, your main muscles that we know on the posterior aspect. Well, this kind of posterior and lateral. These ones that we're going to look at now. And again, if you've not seen this for a while or you're new to the group, because we've had a couple of new people join in, I teach it as if you know nothing. Okay, so so apologies if you do know stuff already, and it's just a refresher for you. But I think that's often quite good. I think that's a useful thing. So your gluteal muscles on the kind of posterior aspects of the back and the lateral aspect, the side, so the outside of your hip, are really really key into especially because obviously we've looked at pathology of some of the other areas of the anatomical areas of the hip. So we've looked at some bony pathology. We've also looked at some the labral pathology as well, and we will cover when we get to it at the end of the muscles, because muscles and tendons tend to only have a couple of things that can really go wrong with them. So they either get torn, and obviously you can have an injury to the muscle belly, or the musculotendinous junction, so where the muscle turns into a tendon. That's usually where injuries occur. But that's usually in bigger or longer muscles rather than bigger muscles, and then especially around this area here, what you find is one of the main issues are tendinopathies. So when we do the pathology for this region, after we've done all the muscles, we'll have a look at tendinopathies and how they occur, and why they need certain types of rehab, and why some things work and some things don't. So, well, as far as we know at the moment. So, yeah, so that's what we're going to explore around the muscles, and this area here is a real key one. Um, yeah, tendinopathies of the gluteal region and the uh, what we call greater trochanteric pain syndrome. Those those particular pathologies are very very common. Those are ones that you'll see again and again. So that's what we'll cover when we get to that bit. So just to kind of sow the seeds of that, and we'll cover that later. So this area here, if you're new to this, this table is your revision table, basically. So if you need to do an exam where you have to remember the origin insertion of muscles, which is just, um, it's it's a really archaic way of doing things. I think because you need to really kind of visualize it, right? Don't get me wrong, I mean, it took me ages to do these blooming tables, so I hope they're helpful, but um, they don't stick in your mind, not like seeing it. And so that's what we're going to do now. So obviously you've got all this information here, so if you need to take a screenshot and you want to use it for like flashcards or something like that, then that's fine. Just crop my head out of it, and then you can but then the video will show you where things go from and to. And we don't really use origin and insertion anymore in anatomy. We call them attachments rather than O's and I's. So yeah, it's a bit of an outdated terminology, bit outdated terminology anyway. So your glute maximus is the biggest muscle on the posterior aspect of your thigh. So it is literally your biggest bum muscle. Okay, so it's the most powerful hip extensor. Excuse me. And yeah, so what we're going to do first is have a look at this. Some of the key things to look out for when we have a look at the video, and especially when you're treating patients as well, or if you're doing exercises for people as well, it's useful to know where these muscles attach. But it's this bit down here. So where the arrow is pointing to there, that's the gluteal tuberosity. So that area there, the insertion point, and this is on the back of the femur. And there's like a ridge on the back of, well, it's not like a ridge, it is a ridge. It's a ridge on the back of the femur that attaches into the that where the glute max attaches into. And if people are suffering from gluteal tendinopathies, it's weird because you automatically kind of think that they're going to be around the greater trochanter area around here. But if you start palpating around this area here, usually people will hit the roof, and it's because it's where the muscle attaches. Yeah, and this is where the pathology lies usually. You can get some discomfort up around here, up around the iliac crest area as well. And if you're not sure of what these bony landmarks are, we did a video on bony landmarks a couple of weeks ago. So bony landmarks of the pelvis. and the hip. Okay, so have a look at that if you're not too sure what they are. So this is the iliac crest, and this is where the glute attaches, and look how far it comes down. So it's coming down to kind of coccygeal area, so the base of the sacrum around that area. So there's a really wide, broad attachment. But if you notice with the glute max, there's nothing here. Okay, so on that kind of middle and anterior portion of the iliac crest, there's nothing around there. So if people are experiencing discomfort there, then it's more likely to be the other gluteal muscle. Well, one of the other maybe one of the gluteal muscles and maybe another one, which we'll have a look at in a second. Okay, because the glute max doesn't attach there. Okay, so it's if you're palpating that area or people are complaining of symptoms in that area, then it's unlikely to be glute max in that particular place. Saying that though, I did a dissection about 5 years ago where we were looking at the insertion of the glute max. And what we found was that there were gluteal fibers, so muscle fibers of gluteal, up at around about L3. In the lumbar spine area, the middle of your lower back, and you could see the clear muscle going across the joint line, and then extending up into the lower back. Okay, so again, this is what you see in the books, but it's there are variations of that. Cool. Right, let's have a look at this. So this is hopefully glute maximus. Fingers crossed. Get that one. Here we go. So gluteus maximus. So the biggest muscle at the back. And here we go. So here's your glute max. Just pause that there. So what I've done again, if you've not seen this before, is that paused? Yep, cool. Is I've put the table from the PowerPoint into this as well. So now you've got the table and you've got the video together. So hopefully will help you again with revision if you need to revise this kind of stuff. So these are the muscle fibers of glute maximus here. And you can see that it changes from being that kind of reddy color, which is the muscle belly, into this white connective tissue here. So more of the tendinous tissue, and then into like connective fascial tissue around here. Here you can see the iliac crest. So this is the posterior ilium, so the back of the ilium. And then you'll see that there's it's not here. Yeah, so there's nothing at the front of the iliac crest from the glute maximus. And this is what I was saying from the picture before. If someone's experiencing symptoms around here, then it's not coming from, well, it's very unlikely to be coming from gluteus maximus. Okay, so that's that there. Let me just play that again. So there's your attachment there with everything removed. That's your sacrotuberous ligament, and we've talked about that when we looked at connective tissue. So it's attaching to that as well, covering the hamstrings, which are here. Your greater trochanter is under there. And then this bit here, this is your gluteal tuberosity. So it's that bit there. So that's that ridge I was talking about. Just go back. It's like all the videos are messed up here. Why is that happening? Bear with me a second. Here we go. Just play that again. Yeah, so right at the end of that video, it showed the ischial not the ischial tuberosity, the gluteal tuberosity, where the glute max attaches. Hopefully. Action. Try again. It's looking good so far. Yeah, here we go. Yeah, cool. So there's your gluteus maximus. Gluteal tuberosity just here. So that underneath there is your greater trochanter. So you'll be able to palpate. There it is there. Okay, you'll be able to palpate that through the gluteals. And then, yep, sacrotuberous ligament, and then all the way down here. So this area here, which we'll have a look at in a sec. So greater trochanter under there. And then around this area, that's your gluteal tuberosity. So that's where your glute max is going to attach. So it's that's where it is. Okay, so it's a very short muscle, very big muscle, perfect for producing maximal force. So that's why it's your biggest hip extender. Okay, so that's your gluteus maximus, and then underneath that, so we'll go kind of layer by layer. You've then got your glute medius, and again, if you have a look here, so there's the back of the ilium. Okay, that area just there, and then we've got the iliac crest all the way over the top, and where the gluteus maximus finished about here, this is what fills the rest of the space. Okay, so it's your gluteus medius that fills that space, apart from right at the front, and then attaching here on the greater trochanter. Okay, so it's a little bit higher attachment point, and again, different position of the muscle, so it will do a slightly different thing. So if you have a look here, we've got medial rotation, so it will inwardly rotate your hip. So turning, if you had your leg straight, then it would turn the whole leg inwards. Okay, and it will abduct your leg if the if you're doing an open chain exercise where the limb is moving. But one of the main roles of your gluteus medius is lateral stability of the hip. So when you take a step, you don't fall to the side, and it's something called a Trendelenburg gait. So you may have heard of that before. But people who have got weakness of the gluteus medius muscle, or a problem with the nerve supply to this muscle, so superior gluteal nerve L5S1, they may struggle with activating that muscle. So then they kind of tilt to the side when as they're walking. It's kind of like a model will walk on a catwalk doing it deliberately, but someone isn't obviously not doing it deliberately. So their hips would drop out to the side. But that's why, because of the orientation of that muscle. So let's have a look at that again for real. Here we go. Excuse me. So gluteus medius this time. So we have maximus before, so the biggest one. This is the middle one, the medius, just underneath glute max. So, and we're just about to layer it on. There it is there. Okay, so again, really big muscle, but covering the front of the crest rather than around. I'm just going to pause that there just so I can point some things out. Yeah, so there's the iliac crest just there, and you can see it's coming all the way around the front. So yeah, again, if people are kind of pointing towards the front of the iliac crest where their symptoms are, then it's more likely to be glute medius that has a problem. And we used to call pain around the greater trochanter area a trochanteric bursitis. Okay, so you may have heard this term before. So we talked about burses on the last session, and so they're a fluid-filled kind of piece of connective tissue that stops friction. Okay, but in between muscles and bones and muscles and other muscles. So when you went to the physio or the GP or whoever, the common diagnosis like 10, 15 years ago, if you had pain on the greater trochanter, it would be called a bursitis. Okay, so that's what it was assumed to be. The only problem is there are so many structures there, so we have no idea what is the structure that's causing the problem, unless you have some kind of imaging, and then even then it's not that useful because there may be other things that don't show up on imaging. But the what we call it now is a GTPS, which is a greater trochanteric pain syndrome. So anything where it's a syndrome, it basically means we don't know what it is. Okay, so you can still give someone a label for what their symptoms are, but to determine exactly what it is really, really difficult, because it could be glute medius, it could be any of the muscles that we looked at last time. So the obturator muscles, the gemelli muscles, the piriformis, the quadratus femoris, it could be any of those. And then depending on the location, and this has changed now as well. So it used to be called a piriformis syndrome, and you'll see if you Google it, you'll see it loads. But we can't be specific that it's piriformis. So now it's a deep gluteal syndrome. Okay, because we know it's something in the deep gluteal space. Yeah, we can't say it's piriformis for sure because we don't know. It could be any one of those other muscles. So which is useful, I think, because then people don't get too hung up on one thing that's causing a problem, because that's very, very unlikely. And also it doesn't really change what we do, because if you treat this area or if you do exercises, you're going to affect them all anyway. Okay. So Martin, Martin had to work on your glute medius after hip operation on both sides. Yeah, it's quite common, that one. Yeah, loads of glute med work after any kind of hip operation, definitely, and also before, to make sure that you're in good condition for the operation as well. So yeah, glute medius here. Let's just play that a little bit more. And then you can see the attachment here on the greater trochanter. So there it is there, just there. So there's your glute medius attachment, all on that kind of, it goes underneath your glute maximus and then pops out and goes all the way to the front of the iliac crest. And then onto the greater trochanter just there. So maximus over the top of that. And then your medius. And then we're on to the last gluteal muscle, which is this one. So this is glute minimus, and always kind of think of this one as a tiny little muscle, but it's not. It's pretty big. Well, it depends on the size of the person and how much they exercise, like any muscles in the body, but relatively big, I guess, because you think minimus would be a small one, but it's not actually that small. So we've got glute minimus, and you can see here it attaches underneath where your glute medius would be. Okay, so glute medius was around here, glute maximus was around here, and they're in layers. So it'll be glute max, take that one away, then you've got glute medius, take that one away, then you've got glute minimus. Okay, so that's the kind of order that they go in. Okay, let's have a look at what that looks like. There we go. So gluteus minimus. It's weird. It feels like I should be drinking coffee right now. That's my normal kind of routine. I don't want to do that right now. Okay, so there's your piriformis, which we looked at last time. And then here's glute minimus just there. And again, if I just pause that, just get a bit of an orientation again. So iliac crest up around here. Greater trochanter is just here. And like I said, piriformis just here. You can see all the rotator cuff of the hip that we were talking about a couple of weeks ago, and your glute medius is over the top of this one. Okay, so that's the one we've just seen, and that would be over the top of this. So that's why you couldn't see this before, because glute medius was over the top. So we've peeled that away, and then this is what it looks like underneath. And if we have a look at the action of it, we've got abduction and medial rotation, exactly the same as glute medius. Yeah, so they both do the same job. They're both kind of helping each other out. Okay, let's play the rest of that. Yeah, so slightly inferior to glute medius. And you can see how far it comes across on the iliac crest and fills that ilium just there. Very short, broad attachment, and then the attachment for this one's right on the front of the greater trochanter usually, but again, it all kind of merges in together with the other, with the glute medius. It's a good question, that. No chance. No. What you might be able to do is, because it does the same job as medius, if you try to activate minimus, you're going to activate medius as well. So, and if your hand is in that position, because medius is on top, you're going to feel that one first, and it's a lot bigger muscle. So you wouldn't be able to isolate it and say that I'm definitely palpating this area. And also, so then if you're feeling around for areas of tenderness around the hip, it could be glute medius on top of glute minimus that is tender, and that's what's sore. And it's only because you're pushing really hard to try and get through to glute minimus that you elicit symptoms. So I would say it's very, very hard to isolate that muscle and be able to specifically palpate it. It's just too deep, and there's too many layers on top of it. That's a good question. Cool. So those are your gluteal muscles. So that's looking at the posterior aspect of the hip. The other thing we need to look at, this is always one of my favourite topics, is the tensor fascia lata and the iliotibial band. Okay, so I think we talked a little bit about this in the knee, but obviously the knee and the hip are very closely linked. Well, they're linked via these structures. And yeah, it's really cool when you kind of break down the words, I think, and look at, because tensor fascia lata, well, it's TFL, and if you live in London, then that's the tube network as Transport for London. But yeah, TFL in this case is tensor fascia lata. So it's the tensor of the white fascia, and the white fascia is the iliotibial band. Yeah, so what the tensor fascia lata does is provides a contraction to the iliotibial band, and it helps. And if we go back a few slides, so if you have a look here, we've got greater trochanter as the attachment point, greater trochanter as the attachment point, iliotibial band as the attachment point. So the ITB is the insertion for your glute maximus muscle, and it's where 3/4 of it attaches onto. Yeah, so 3/4 of it are attaching into the iliotibial band, and then that iliotibial band runs all the way down the side of the leg and attaches around the knee. Well, we'll have a look at that, because it's not as simple as that. Let's just go to the TFL. So this is your tensor fascia lata, the TFL. So it's where anatomy gets a bit confusing with all the acronyms. So we've got TFL, ITB. So tensor fascia lata is TFL. ITB is iliotibial band. So going from the ilium to the tibia. And it's, well, you'll see in a minute. It depends on how it's dissected, whether it looks like a band or not. So here is the muscle. It's right at the front of your iliac crest. Yeah, right on the, like that first inch. So this bit here is the ASIS, so the anterior superior iliac spine, just here, and that is where it starts. Okay, so it's right in there. So if someone's got real tenderness right just posterior to that point, it may be glute medius, but it's likely to be tensor fascia lata as well. Okay, so yeah, it's one or the other of those, because they do very similar things. So we've got abduction again and medial rotation, and the little rhyme is tensor fascia lata, gluteus med and min, all abduct the hip and rotate it in. Okay, so there you go. I'm available for kids' parties. So we've got tensor fascia lata, gluteus med and min, all abduct the hip and rotate it in. So that's a nice way of remembering those muscles around that region there. Cool. Right, let's have a look at this one. Just get rid of that. Okay, here we go. Okay, so we got iliotibial band and tensor fascia lata. And I think this is a fairly long video, so I might have a few pauses. Here we go. Okay, cool. So this is the first thing. The iliotibial band is not a band. Okay, this is the ITB. I think we did have a look at this when we did the knee. So this is the top of the hip around here. Your patella is around here, And this yellowy stuff, this kind of white yellowy stuff, that's the fascia that surrounds your whole leg. Okay, and where the glute maximus attaches and the tensor fasciolater attach, and where they both pull on the iliotibial band, it then starts to create a thickening along the line of force. And that's why we get this thicker area of connective tissue on the outside of the thigh, which we know as the iliotibial band. But in real life, it looks like this. Okay, so the only way you can isolate that band is by taking away all of the other tissue. So it's yeah, it's not really a band like that. Sorry, Simon, I just missed your question. So if the glute minimus inserts into the greater trochanter, could the minimus be the issue if there's pain in that area? It could be, yeah. It could be minimus, it could be medius. And again, you know, the point at which they attach could lead you to one more than the other, but because they don't attach onto one bit and then everything else leaves it alone. The medius will attach in there as well, and then they'll just merge together. So it's really difficult again to isolate it and say, oh, it's definitely that attachment or definitely another one. Yeah, it's a good question. Cool. Right, let's have a look at the rest of this. So there's your IT band, which is not really a band. Look at it wrapping around the whole leg. So your hamstrings are under there. Okay, you can just about make out the thickening of it just here. Look, can you see that thickening there? Yeah, and then there's the TFL, the tensor fasciolater, just up there. Okay, let's just play this a bit more. So there's your kneecap, there's your patella, and then there's the thickening. Yeah, sometimes it's called your iliotibial tract. So again, we've got more names for the same thing. Okay, so ITT, some people call it, and yeah, so your TFL, your Transport for London, is just there. It's lost on people who've never been to London or don't live there. Okay, and then we're up there. We've got your iliac crest, and then right down here, this is the attachment point. It's on Gerdy's tubercle on your tibia. I'm just going to pause that there now. This is the image we're used to seeing, okay, is this one here. So you've got the IT band, which has been cut. So when you see images like this in books, obviously normally you don't see real life muscles. You just see the drawings of it, and it just looks as if there's this band and then there's all the muscles are neatly around it. The reasons why the muscles are neat and all around it is because they're kept in compartments, and they're kept in compartments by the connective tissue. And the outer layer of that connective tissue is what you've just seen. Okay, so underneath the IT band, there is a direct connection to the femur, and we looked at this when we looked at the knee. It's called a septum. So if you, I likened it to the Trivial Pursuit wheel and the wedges that you get in the Trivial Pursuit. So in the anterior thigh, so the front of the thigh, there's a wedge, and then the container that those muscles go into are surrounded by connective tissue that cover it around the outside, but then also anchor it to the femur on the inside, and it's contained in a wedge. Okay, and then your next wedge is the hamstrings around the back, and then the next wedge, there's only 3 on this Trivial Pursuit. The next wedge is all of the muscles on the inside of the thigh, so your adductor muscles. So the thigh is split up into compartments, and all around it is connective tissue, and then that connective tissue attaches to your femur. Okay, so that's what we're seeing here. We're seeing the kind of the top part of the septum. Yeah, so that's what's underneath there. So that's where your IT band comes from. Okay, those are the muscles underneath. So vastus lateralis, there's your hamstrings. And just underneath there, that's where you can see where it attaches to the femur. Just going to pause that there a second. Bear with me a sec. Sorry, dog's barking. Oh, am I back? Yeah, back. Sorry about that. Dogs were barking, so I had to get rid of them. So we got IT band, iliac crest just up here, and then there was Gerdy's tubercle there, and then there's your patella, and then this was the image that we just saw. So there's your IT band, and then when he kind of hooks in and pulls it back, you'll see the connection. So you can see the muscles underneath, and then just in here, this is where the IT band there connects into your femur. Okay, and it divides the front of your thigh to the back of the thigh. Every space is full of fat. Yeah, that's where your IT band will attach. So there it is coming up there. So there's your gluteus maximus coming in. So glute max all around there. There we go. There's your TFL, your tens fasciae lata. And then there's the attachment for the TFL just there. Yeah, and then straight into the iliotibial band. So there's no bony attachment for that tens fasciae lata. It go well apart from the superior part. The inferior part just goes straight into the iliotibial band and then joins in with glute maximus. So if we think about what when we were talking about the rotator cuff of the hip, we've kind of got two. Yeah, so you've got a deep one, so that's all of the gemelli muscles, the obturator muscles, the piriformis and the quadratus femoris. So all of those really small, very, very close to the hip joint. And then we've got these gross muscles, so like the kind of like the deltoid, like the deltoid in the shoulder, but we've got one around the hip, which is your glute maximus, and then your TFL joining together, going over the greater trochanter and then going all the way down to the knee. So you've got that kind of those big muscles stabilizing and creating the movements superficially. Okay, so we've got kind of two layers. Right, cool. We have got a bit of time left, so let's have a look at some of these medial thigh muscles. So again, this might be useful for those of you that are revising and need to remember what muscles are what. So we've got three ducks pecking grass. Okay, so that's what this image is. So we've got three ducts, which are adductor magnus, adductor brevis, adductor longus. Okay, so those are your three ducts. Pecking is pectineus, grass is gracilis. Okay, so three ducts pecking grass. Those are your muscles of the adductor, so the medial thigh. Okay, that's how I've always remembered them. So I thought it might be useful. So the nerve that supplies these areas, this area, is the obturator nerve, and we'll talk about that when we get to it. And it supplies the adductor group. Okay, so the adductors as a whole. And obturator means to close. So if we think about that, that makes sense. So that nerve has been given that name because the muscles it goes to close the legs. Yeah, so that's quite useful to know. And it's just remembering that obturator means to close. So one of the really big muscles, and we did look at this in the knee as well because we were focused on this area here, which is the adductor canal. Or hiatus, this area here where there's a little gap, is where your blood supply goes from the front of your thigh to the back of the knee. So that's really key. But now we're focusing on the top part. So if you want to know a bit more about that, then have a look at the knee videos. So we've got adductor magnus. Magnus just means big. Okay, it's the biggest one. It's like maximus, magnus, all of those big muscles. So let's have a look at magnus first. Here we go. Okay, so adductor magnus. So this is what you'll see in the books. There are two parts to it. So we've got adductor magnus muscle mainly here. There's the hiatus that we were talking about before. And it through that gap is where your blood supply will go from the front of the thigh to the back of the knee. And we've got kind of two muscles, because one will kind of adduct, and part of the adductor magnus is supplied by the sciatic nerve. If I just pause that there. So can you see like that part of the muscle there? Yeah. So that one only goes onto the femur. Well, they both only go onto the femur, but because of the angle of it, you can see that if that muscle shortens, it's going to adduct the hip. Yeah, it's going to bring the hip closer into the midline of the body. See the fibers on this one, or this part of it, is slightly different. They go straight down. So what they do is they assist with hip extension. Okay, so the adductor magnus is often called the fifth hamstring. You've got your biceps femoris, so two heads, semimembranosus, semitendinosus, and then the adductor magnus. They all do hip extension along with glute maximus as well. And sometimes you'll get injuries in this glute, in this adductor magnus, because of its dual role. Okay, so you've got a very long tendon that attaches down onto the supracondylar ridge of the knee. Again, we covered that when we looked at the knee. But if we look down here, we've got obturator nerve and tibial part of sciatic nerve supply this muscle. Yeah. So this part here, the bit that adducts, is the obturator bit, and that bit there that extends is the bit that's supplied by the sciatic nerve. All right. So that's why we've got two nerves there. So, but when you look at it in real life, you can't really tell the difference between the two. You can just about make out the fiber direction changes. So, but look at that, it's massive, huge muscle. In fact, if I just pause that there, yeah, you could probably make it out there. So see the fiber direction there, and then this stuff goes down this way. So these fibers head this way. Yeah. So we've got fibers in that direction will be your obturator nerve activated. And then this one here, or these fibers here, because they're the extensor ones, those will be your sciatic nerve. Okay. So that's your first of the three ducks pecking grass. And that is us for today. So thank you for joining in, guys, those of you that were here. Good to see some of you again. Haven't seen you for a while. So we're back on Monday, usual time, 10 o'clock. And I'll cover the rest of the the adductor muscles. And we'll cover all of that. So we'll do a bit of a recap of what we did today, and then we'll cover the adductor muscles, and then the last bit, we'll do some of the hamstrings, but we've covered a bit of those already. But we'll have a look at it towards the hip end. Okay, so where it attaches on the ischial tuberosity. Cool. Thanks, Martin. No problem. Yeah, good to see you again, mate. Cheers, Simon. I will see you guys next Monday if you're there live. If not, then on catch up. And just drop any questions in the group if you've missed the live show. Cool. See you again.